Thanks, Sophia. Hi, everybody. I'm Stacy Frisch. I'm one of the EM fourth years. I'm going to be talking today about payment models, reimbursement. This is kind of going after Abdullah's talk, if you guys were there, on documentation and billing in the admin and policy lecture series. So historically, payment was based off of patients and the number of patients, the number of procedures, and more recently there's been a move towards more value-based care, and we're going to talk about how that move has happened and how it actually works. You should care about it because in some places your reimbursement as a physician is going to be based off of the reimbursement that the hospital gets, and your salary might be based on the number of RVUs that you accrue. And so it is important to know what where these numbers come from and how you can improve them for your facility. So these are some things that we're going to talk about today. We'll talk about historical reimbursement through the Centers for Medicare and Medicaid, which set up the traditional payment process, which is the fee-for-service model. We will talk about how private payer reimbursement is a little bit different from that model. And we'll move into the move towards quality-based care with pay-for-performance models in the quality payment program. And then we'll touch on some new trends in healthcare like ACOs, accountable care organizations, and bundled payments, as well as trends in healthcare consolidation. So starting from the beginning, the Centers for Medicare and Medicaid have the traditional payment process. This is the fee-for-service model. Essentially, a coder sifts through your documentation, and they look to see how your history, your physical exam, your review of systems, your diagnosis, and the medical decision-making that you do correlates with what's called relative value units. A relative value unit is basically linked to the reimbursement that the hospital receives, and I'll show you that on the next slide. The current procedural and terminology codes are assigned to your visits, and more diagnoses would be more CPT codes. I think you guys are all familiar with this when you log in the diagnosis on Epic. The way that these CPT codes are created is by what's called the American Medical Association CPT editorial panel. This has one member at least of every specialty and also has different stakeholders such as insurance companies like Blue Cross Blue Shield, America's Health Insurance Plans, and the American Hospital Association. So I just want to make a point before I delve further that you get two bills when you go to the hospital. One bill is a technical bill or a hospital bill, and the other bill is a professional bill, which is a bill for all of the providers and physicians that you see. This lecture is going to be talking about the professional services bill. We're not going to delve into the hospital bill. That's outside the scope of this talk. So there's four main types of CPT codes. There's the evaluation and management codes, critical care, observation, and procedures. For evaluation and management, this is what's called your level 1 through 5 chart. Your level 5 being the more complex patient care and subsequently the higher reimbursement. This is based off of a number of factors. Like I said, history, physical exam, your medical decision-making. Also, if you document that you counseled the patient on anything, and care coordination, as well as the nature of the presenting illness. The critical care CPT code is something that's often cited as a place where we as emergency physicians are not necessarily maximizing revenue. And this is sort of a leading source of revenue lost because it's often undercoded for what we can code as critical care billing. And that's because of the way that it's documented or rather not documented. You might be more aware of this if you move to an institution that is more profit driven, where people are going to be more frequently looking at your charts and giving you feedback on them. And the other types of CPT codes are procedure specific and observation. So I mentioned earlier that RVUs are associated with reimbursement. So in the column on the left, you see the level 1 through 5 chart and the amount of associated RVUs. Every year, the Center for Medicare and Medicaid Services comes up with a conversion factor. That conversion factor multiplies the RVU by the conversion factor to come up with the reimbursement amount. And CMS has the ability to change this conversion factor every year. So this year, the conversion factor is $32.41, which is actually a substantial decrease from the previous year's conversion factor. It's actually a decrease of $3.68, which is more than 10%. So this is something to keep an eye on. And in terms of private payer reimbursement, so previously I was talking about the Medicare and Medicaid models, but private insurance companies are not required to reimburse based off of an RVU model. So most of them do still utilize fee-for-service models, but there's been some push towards more innovative reimbursement structures. Commercial insurance companies basically have what's called a fee schedule, which is an individual contract or contractual rate set up with a hospital or an insurance company. It's between the hospital and the insurance company, or physician group and the insurance company. This can include something called capitated amounts, which is monthly per member payment amounts to try to reduce the overall cost for delivering the care to the same patients. And while the private payer rates are not necessarily correlated with Medicare or Medicaid, when Medicare or Medicaid decreases or increases their reimbursement for a specific code or procedure, they often follow suit and do similarly. This is a study from Kaiser, and they found that across multiple different diagnoses, the rates for reimbursement for private insurance companies were about, on average, 2 times higher than the Center for Medicare and Medicaid Services reimbursement rates. So in order to understand how we're getting from this old school model of fee-for-service towards value-based care, you have to understand a little bit of the history about it. So what I've described to you previously is the fee-for-service model, which is based off of the volume of patients that you see and the procedures that you do and how well you're documenting your critical care time, as well as observation. So currently, there's a push, like I said, towards value-based care, which would incentivize delivering quality care, but also utilizing your resources efficiently. So in 1997, the Balanced Budget Act set up what's called Medicare Sustainable Growth Rate. The goal of this was to correlate the growth rate of Medicare payments with the gross domestic product. And the reason was because healthcare costs were rising substantially, way beyond the gross domestic product. And so they wanted to basically control for the rising cost of healthcare and to decrease the healthcare related debt. However, this failed because it did not account for the rising cost of medical technology, the increased resource utilization, as well as the increasing complexity of patients and the increasing age of our patients. Basically how this would work is every year there would be a comparison of the sustainable growth rate with the gross domestic product, and then they had the ability to modify the payments based off of that. However, Congress had the ability to kind of go back and renegotiate this modification. And in fact, they stopped physician payment cuts 17 times during the 12 years that this policy was enacted. So there was never actually an adjustment for the over expenditure of the healthcare system. So the policy was failing, and in 2015, it was replaced with the MACRA policy, or Medicare Access and CHIP Reauthorization Act of 2015. This was signed in by Obama, and it basically tries to move towards value-based care and uses quality metrics, and I'm going to give you some examples of those. So now we have what's called the pay-for-performance model, which incentivizes providers based on quality metrics that are supposed to be patient-centered and also circling on using less resources to provide quality care. It's not based off of the number of patients that you see or the outcome of those patients necessarily. They established, as part of this, the Hospital Quality Initiative that was rolled out by CMS after 2 reports from the Institute of Medication in 1999 to Err is Human, and in 2001, Crossing the Quality Chasm. The goal of the Hospital Quality Initiative was to kind of collect and distribute data that was objective and easy to understand about hospital and provider performance across several domains, so that it would be open access and so that providers and hospital systems would be encouraged to provide better care. In 2003, the Medicare Prescription Drug Improvement and Modernization Act set 10 initial quality metrics that were going to be what we base our reimbursement off of. And by 2007, there were 74. So they're always kind of looking to create additional quality metrics, and they're created by quality metric group, which includes multiple different organizations, advocacy groups, medical societies, the 3 biggest ones being the National Quality Forum, Physician Consortium for Performance Improvement, and the National Committee for Quality Assurance. So under these quality payment programs, a hospital system or a group of doctors has 2 different payment options that they can opt into. One of them is called MIPS, which is the Merit-Based Incentive Payment System, and the other one is called APMs, or Advanced Payment Models. So MIPS is open to individual providers, APMs is not, and we're going to go into some of the differences between these. So both of these are ways to reimburse based off of quality, and they basically encompass different sorts of metrics to do so. So MIPS uses a scoring system that's based off of 6 characteristics, the ones that you see on the screen there. It's based off of quality. So for example, reducing unnecessary head CTs for minor blunt trauma in adults. And I think you guys have seen this in the T system, a throwback to UHB's T system. And it also looks at cost or total spending per capita or per Medicare beneficiary, meaningful use of the electronic health record system, clinical practice improvement opportunities like a prescription drug monitoring program like iStop that we use, and documenting that. And it also involves a small practice bonus and a complex patient bonus, as these can make practices incur increased expenditures. So based off of MIPS, which you can opt into, these are opt-in programs. But most providers or physician groups are opted into one of them. Based off of MIPS, you can see either a positive or a negative decrease or increase in your reimbursement. Initially, it was 4%, but now it's up to 9% as of 2019, I believe. And this is based off of the comparison of your score, of this aggregated set encompassing these 6 characteristics, and comparing that to a median MIPS score. So MACRA also started what's called advanced payment models, or APMs, and this allows you to take an even bigger risk on your reimbursement. Essentially, it's more risk for reward. You can elect to have an additional 5% incentive for decreasing the cost, but delivering quality care to your patients. And one thing about APMs to note is that it's not generally used in emergency medicine, and the reason is because it does not account for acute unscheduled care, which is what we are often providing. So in response to this, ACEP created their own quality program called Acute Unscheduled Care Model, or AUCM, that provides us with the opportunity to participate in a program that's similar to the Advanced Payment Models program, or APM. And this basically rewards you for post-discharge coordination, but it also makes you monitor post-discharge events. So the score encompasses reducing deaths, reducing repeat inpatient visits or readmissions, and also observation stays. And at UHB, we participate in MIPS. So this is just an example of Randy and Subi reminding us that we need to be mindful and do our MIPS. I don't know, are they incorporated into HealthBridge? Sure. Are they incorporated into HealthBridge? Yes. Okay, yes, they are incorporated into HealthBridge. So we got to continue to do our MIPS for reimbursement. Okay, I have a question for Tarek. Tarek, when you rotate at a specific hospital near Industry City and you want to readmit a patient for, let's say, CHF or pneumonia, is there anything that the care managers tell you? Have you ever run into this?
I have. There's an issue where if it's within a certain amount of time, they get readmitted, but they don't get compensated for that.
Yeah, so Tarek said that if it's within a certain amount of time, they essentially don't get compensated for that readmission. And that's correct. And that's based off of the hospital readmission reduction program. I've had care managers say, well, can't we admit this guy for his hypokalemia instead of his CHF or something like that, which is really a way to get around the hospital readmission rate increasing. They're specifically monitoring 3 different diagnoses, and that's pneumonia, CHF, and acute MI. So if it's possible to have the diagnosis appear to be something else that the patient is readmitting under, if that's an accurate diagnosis, then that's a way to get around this reduction. And it's up to a 3% reduction in reimbursement if the rate exceeds the median rate. So I'm going to move in to talk about some quality metrics that pertain to us in the emergency room. Decrease in central line infections, topical therapy for acute otitis media as opposed to systemic therapy used in patients that are 2 and older. Administering RhoGAM to Rh-negative patients who are at risk for fetal blood exposure, and decreasing the CAT scan use for primary headache with normal neuroexam, which, as you recall, was a topic of radiology's lecture to us in one of these conferences. Some inpatient quality metrics that pertain to us involve length of stay in the ER, including pre-dispo and boarding times, and decreasing these length of stays. And then outpatient quality metrics that pertain to us include median time to EKG, aspirin for MI, so giving aspirin to patients who are eligible within 24 hours of acute MI as long as there are no contraindications, decreased door to doc time, and decreased left without being seen, which would make this guy very happy. So we're moving towards a quality-based care system, but there's still a lot of room to grow. Despite broad agreement that quality metrics are the way to move towards this better form of reimbursement, there's still controversy on how to exactly measure value and how to implement these incentive programs. And they're all new, and so there's a lot of room for improvement. A few of the major arguments surrounding the pay-for-performance models involve 3 main things. One of them being that if we're, as providers, being incentivized based on all these metrics, it might decrease our our internal incentive or internal motivation to be providing the best quality care to the patient in front of you, rather than just trying to document and bill as up to the highest level. One other complaint that people say is that it doesn't really account in emergency medicine for the undifferentiated complaints that we see. So most of these quality metrics are based off of diagnosis code. Like I said, 2 of them are based off of patients for acute MI specifically. So it doesn't really account for the fact that we are seeing patients with undifferentiated chest pain, undifferentiated abdominal pain, and we're the ones who are deciding whether do they need a workup for a PE, acute coronary syndrome, do they need a workup for pneumonia. They don't really base that. That's not really captured in terms of value as the current quality metrics are set up. And then the last thing that they don't encompass at all is sociodemographic factors, which we know play a lot into patient outcomes. So some people are worried that these new quality metrics are going to disincentivize people from taking care of these vulnerable populations. And that's because these patients have a lot of healthcare disparities, which might worsen their outcomes, and the physicians or hospital groups who are taking care of them are likely to get dinged based on their poor outcomes, which they may not have total control over. Some people argue that it should be risk adjusted based on patient socio-demographic factors, or that more resources be provided for practices taking care of these more vulnerable populations. So some other new trends in healthcare are the starting of accountable care organizations. These started after the Affordable Care Act, and they basically incentivize a group of doctors or hospitals to reduce their costs by allowing them to receive a percentage of the savings that they accrue on their Medicare or Medicaid payments. Since the ACA was passed, there are over 1,000 ACOs, which encompass over 33 million patients across the US. And while most of these ACOs don't actually involve emergency medicine physicians, they do rely heavily on our work. So if unavoidable ER visits take place, or if there is increased readmissions, the ACO will have a harder time with demonstrating cost savings. So this incentivizes the ACOs to really increase preventative care in the appropriate environment and avoid unnecessary costs. And another new concept as part of the ACA is the concept of bundled payments. So this is to align the incentives of the hospitals and the providers to increase the quality, but also reducing costs. They term an episode of care basically all of the services provided for a patient for a particular diagnosis. So for example, a patient is in the hospital for congestive heart failure exacerbation, or a patient is in the hospital for a total knee replacement. And there's one prospective model and one retrospective model. The prospective model, basically they say, okay, usually for a total knee replacement, you get $40,000. So we're going to give you $40,000 and you can do whatever you want with it, but any complications are up to you, and any readmissions are up to you to cover. The retrospective model is this example that I have shown here. Basically, a patient is hospitalized. CMS gives a bundled payment to the hospital. So for example, for acute heart failure exacerbation, they'll say, okay, here's your $10,000 for this hospitalization. And with that, you need to cover all of your complications and your readmissions. Then the hospital calculates what their actual cost was. And the hospital, if they have a cost that is demonstrated to be lower than what CMS has agreed upon, they get to keep what's called a gain share, which is a portion of the essentially difference between what the hospital used and what CMS gave them. If their cost is over what CMS gave them, then they have to pay more. And so this incentivizes them obviously to reduce their costs. So you might be thinking, how does this necessarily affect you? Because, in the ER, we're seeing patients and we're not necessarily always thinking, especially in our academic institutions, about how this is going to play out in terms of reimbursement. But the pressure to decrease readmissions and also to coordinate outpatient services is going to be increasing in the emergency room, especially if you work at a more profit-driven place, some of the community places or the less academic places. So you're going to start to see opening of more observation units, maybe sending patients home with Holter monitors, allocating additional resources for follow-up calls, which we're already starting to see on both sides of our street here, and coordination of home healthcare agencies or rehab referrals so that we don't necessarily need to admit these patients for these services. Okay, so one other trend that I want to touch on is healthcare consolidation. This has been a really big trend, especially through the advancement of ACOs. So hospital mergers, as well as the conglomeration of pharmacies with hospital systems, with insurance companies, they're kind of all grouping together. It's sort of necessary for the care coordination that's needed in order to reduce costs. The practice consolidation affords physicians the opportunity to have a larger hospital network, which allows them to not only have financial security of the larger hospital system, but also the benefit that the hospital system can have a greater power with negotiating reimbursement rates with their reimbursers or their stakeholders. And some opponents of this worry that if we're taking away the practice ownership from physicians and moving it towards business executives and administrators that are non-practicing, they may be more focused on the reimbursement aspects rather than actually providing quality care, which is something that's not necessarily captured in the current so-called quality metrics. So with all of these conglomerates, we're seeing a lot of different types of merging. There's horizontal merging in where two providers are merging or two hospitals are merging. These are basically mergers of the same supply chain level. And then there's also vertical consolidation. So this is, or vertical integration. This is when you see like hospitals with physicians or insurance companies with pharmaceutical companies. So for example, CVS Aetna Health or Cigna Express Scripts. And we're going to be seeing a lot more of these coming up. One interesting example that I just want to point out about mergers is the company called Haven. I guess, I think many people are familiar with it, but if you're not, it was the CEOs of three very large corporations, Amazon, Berkshire Hathaway, and JP Morgan. In 2018, they decided to form this group called Haven, which their goal was to capture all of their employees, over 1 million employees, within this healthcare network. They were going to insure them by themselves, and they were going to work with directly with pharmacy companies and act as their own insurer, therefore decreasing their costs by sort of cutting out the middleman, cutting out the pharmacy management benefit companies, cutting out the insurance brokers, and also the insurers that currently exist. So they thought that they were going to be able to better control costs and also have quality care for their patients. But this past summer, Gawande stepped down during COVID, basically saying that he needed to devote more time towards stuff that was going on with COVID. And then last week, actually, they canceled the venture, saying that there was no way that they were going to be profitable. And this just underscores the complexity of the healthcare reimbursement system, that even these three large companies were unable to, with all of their contacts, provide healthcare at a reasonable cost for their employees. So just a summary of the things that we talked about today, the sort of traditional payment model, which is the fee-for-service model that Center for Medicare and Medicaid is using. Private payer reimbursement, which is not necessarily based on the fee-for-service model and is often higher than the traditional reimbursements. The pay-for-performance model, which is increasing as part of the ACA, and we're going to start to see a push towards more value-based care with the quality payment programs. And then some newer trends in healthcare, like the accountable care organizations, bundled payments, and healthcare consolidation. So with all of this, there's a lot of changes going on with the reimbursement system, and there are ways to be informed and advocates if you are interested in learning more. You can basically read more about the changes, learn more about MACRA and about new private insurance company payment models. You can also be involved in learning more about quality metrics and the ones that affect the emergency room, and also making sure that you know which MIPS or which metrics your institution is following. And you can even help in developing quality metrics. These committees that are developing these quality metrics are recruiting, and I don't know if they're recruiting residents, but they definitely are recruiting emergency medicine doctors to their committees. So that's another option of ways to get involved and stay involved. And I'll take questions.
So Stacey, that was fantastic. You covered a lot of information, and you did it very well. I could make a dozen comments, of course, but I won't. But I'm going to say that a great place is your first or second slide. Kaiser is a great website. There's a lot of educational things, and it's pretty basic when you start out. So that's a very good thing to do. When you talk about DRGs and stuff, it's not just congestive heart failure. It's congestive heart failure with left ventricular dysfunction. It's congestive heart failure with increased systemic vascular resistance. So and when you say, what, who cares? We all should care, because especially with COVID, hospitals are taking such a hit on reimbursement. And the reason why Haven dropped out of it is because COVID patients are so expensive to take care of. Because think about it, every time somebody goes in there, it's all PPE, so you slow down dramatically. And this is really important, because if not, you're right. These Harvard business grads are going to cut the docs out of the equation. And it's just going to decrease the physician compensation. So it's something that, you know, I've been singing about for 20 years, and I hope that everybody really takes this to heart. Excellent job.
Thank you. Were you guys able to hear that at home?
I took my mask.
Okay, yeah.
I think the self-application is really important, and I think that most physicians don't know about it, and that's what the importance of the billing company comes into play. Because if the billing company's there, they'll pick the diagnosis with the highest reimbursement, and they'll get you more money for your work. But I think it's really important that the billing company is involved, especially with the physicians. We need feedback on what we should be choosing just to get more money out of our work that we're actually doing.
I think it's really important for us to know too, because those diagnoses that you talk about, there's so many more resources that take care of those patients at home. Working with the care managers, a lot of times you don't have to admit them because they can get, like for CHF, they can get home nursing care or something like that because they don't want these patients to stay at home. And then I just wanted to put a question to you. Says you're doing all this research and everything. Is there anything that specifically you would change your practice or maybe change kind of what you think about when you look for a place to work?
I think I'm gonna be, my MonMD where I'm going is actually RVU based. So, you know, I'll definitely like review the large procedure RVUs or the critical care RVUs and try to see exactly what you can document for and how to document it, which I don't do right now because I think currently our attendings are doing that. But that'll be one thing that I'll change and have to work more on.
Yeah, I think we definitely undervalue the critical care documentation. I think Dr. Holt is over here saying that we think of it as an exacerbation that we gave FE and NEMS and steroids. It's just that they, you know, walk in the park. But that can be critical care documentation.
Great lecture. A lot of the surgical specialties are also now starting to utilize observation to try to avoid that 30-day readmission, specifically cardiothoracic and bariatric surgery. Pretty hard as well.
Dr. Youssef is saying that a lot of the surgical specialties are also utilizing observation, specifically bariatric and cardiothoracic surgery, to decrease their cost, their readmission rate. Anybody at home? Okay.
Well, actually, can a resident document critical care time and if so, is it the same for EKG doc? No.
It's good practice.
Yeah.
You do it, but it won't get done.
Okay, your attending management, if you see your attending's not doing it, point it out to them.
Oh yeah, point it out to me.
This building is a little sketchy.
Thank you. That's what I want.
I think so.
This is why we
Right.
need a single payer system so we can get rid of all this crap.
So that is true.
Yeah.
I don't